welcome to CSB 336, Sepsis, Communicable and Infectious Diseases. Now, a trend that you probably find with most of the lectures that I've given is, one, I don't show a video of myself, just because I've got multiple screens going at the same time, so I apologise if you're just having to listen to a voice. But secondly, I'll generally reiterate the sheer amount of content that any one lecture would require to do it justice. And sepsis is no different. Sepsis is considered one of the greatest killers of the population, but is somewhat unrecognised. And you would have seen, or you may have seen in recent years, a lot of media attention about this new condition that's been around for a long time but no one knew about, which was sepsis. Which is not the case. Obviously, in medicine we knew well about sepsis, but often because the people most prone to this had comorbidities, it was put down to other causes rather than necessarily the infective cause to begin with. But what they have figured out is that this sepsis needs to be identified early. At-risk patients need to be identified earlier than that, and treatment needs to be initiated earlier. And there's been ongoing disagreement over paramedic role or pre-hospital role in treatment of sepsis and infectious causes of sepsis around antibiotics, and we'll touch on that a little bit towards the end of the lecture. But for the moment, what's important, and the way I've structured this lecture is because of the sheer volume of information for this, but also the fact that we're going to be doing this in an online environment, it opens up the opportunity to use the lecture to create thought and link to other resources that are out there. Certainly the days gone where you're going to get all information in a lecture, days gone by where that was the case. Now that there's so much information, it can't be contained in a single lecture or even a series of lectures, but it's all available, widely available on the internet, and just knowing where to search and what are reliable sources of information is important. And I'll link to a few of those throughout the presentation. So if you're looking at the slides at a future time, not listening to the recording, you'll notice that where there's underlined, that's a link to something that we're reading about. For the moment up on the screen, you can see I've got the Queensland Government's Clinical Excellence page. So this is a group that oversees clinical practice throughout Queensland, make sure that we're focusing and instigate such programs as required. And some of you may be familiar with something like Ryan's Rule, which is over a child who was dismissed as not that sick by medical professionals, unfortunately did later die. And now there's a rule in Queensland that as a parent or as any patient, you're not happy with the diagnosis or the treatment being given to you, you can use Ryan's Rule to request a review by a senior user consultant, even of a different specialty, for your presentation. Anyway, so moving along. Now I'm going to wind this presentation around a case study to give you some context, sort of guide your thought process as you're investigating this. I'm not going to give you all the answers as we go through this. I will give you links to potentially give you those answers, and even at the end of this lecture you may leave with questions. The intent is that you will then go and hopefully research a bit more and have those answers. Obviously, there's lots of things that can cause sepsis. I'm going to focus on this particular case study, and then I'll touch on some of the common causes later. So this is a 56-year-old gentleman. He's a diabetic patient, and he has a high temperature. As you can imagine, this call coming into an ambulance service is generally not going to be triaged to a high category. And in this case, you can see this patient's been waiting for 2 hours, which is not an unusual scenario in the way the coding is done of patients that call with these particular symptoms, unless they provide further information that codes them higher. Anyway, so what is an infectious disease? So it's any disease caused by microorganism, and which can be transferred to new individuals. So this is obviously anything bacterial, viral. We tend to think less about viral causes simply because until recent years, and even then it's controversial, there hasn't been much in the way of treatment for antiviral medications. That has changed, and we're not going to go into that into too much detail. But also potentially in patients usually when they're immunocompromised, the sepsis or the infection can be caused by a fungal agent, although quite uncommon in the immunocompetent patients. The communicable disease, on the other hand, is an infectious disease, but that one that spreads quite readily. Now, as I record this lecture, we're in hopefully what's the tail end of COVID-19, but I think we've all been given a crash course into not just infectious diseases, not just viruses, but certainly in the role of public health and the statistics that surround us. So some of the terms will be familiar to you just by having watched the news in the last few months. Unfortunately, or maybe fortunately, we are more aware of infectious diseases and their impact on people in probably in the last number of years. So in terms of causal factors for any infection, and then obviously that progressing into something as bad as sepsis, they talk about three things, a triad. So there's the environment, so that's things like climate, housing, healthcare settings, travel, the host, so his factors, and whether it's human, obviously in this case specifically human, and then the agent, virus, bacteria, fungi, parasites, and so forth. So in that case study, I want to bring it back to that. First thing that we find is that we should be pulling information from even the dispatch information as to the risk profile of our patient. So in this case, he was a male patient, and what we know is that for some reason males have a cell-mediated immune response. And if you click on the link that I've provided, it will take you to an article on the gender differences in sepsis. Now, I'm not going to obviously read through that, but what we do know is that males seem to be have an increased risk of sepsis. So, just in that initial information, we found a criteria that increases the risk profile for this patient. Now, we then go on, and we also noted in that dispatch information he was a diabetic. Now, for most cases, we'll probably dismiss that as well. If he's not hypoglycemic, what's the relevance of diabetic? And we see paramedics routinely do that. But what we know is that diabetics are at increased risk of sepsis, and certainly because of some of the microvascular changes that actually have increased risk of certain ulcers and such that may be a source of infection. We'll talk a little bit more about that in our case study. But here you go again. I've provided a link to a publicly available manuscript that talks about the impact of diabetes and how that's affected in sepsis. And I encourage you to read as much of these, preferably not just the abstract, but as much as you can. So then we go, well, what's the agent? Now, in the pre-hospital setting, we're not going to know what the agent is. We can get a suspicion based on things like time of year. There's an increase in certain viruses over periods of time. Also looking at if we know where the source of infection is, there's things like skin infections are more commonly caused by Staph aureus, for example. But typically we can have a suspicion, but we're not going to know. So what I've done here is I've linked you to Medscape. Now, this might require you to do a login, but you can certainly join up free. It's a resource that if you haven't already joined up to, is really beneficial. It gives you very succinct information, clinically relevant information. It's made for clinicians about some of the risks. And here it talks about the patients with diabetes mellitus and their infection risk and various sites of infection that you may find. Now, typically we think of things like UTIs as low risk. But certainly, if you're an at-risk person, or you are immunocompromised, for example, even the common cold can potentially kill you. So it's important that we understand our patient, and everything, the decisions that we make are very specific to that patient rather than our suspected diagnosis. So now, in terms of an immune response, I'm not going to go into a huge amount of detail in this system and so on. It's very incredibly complex, but simply put, there's innate responses and there's acquired immunity. So, things like the external barriers, your skin and your mucous membranes. Your skin is not just there as a covering. It's as we know, it's the largest organ in your body, and it plays a big role in preventing the flora and fauna of the world getting into your blood system or into your body. Then there's chemical barriers, antimicrobial proteins, proteins that occur from naturally occurring bacteria. So we know that we have good bacteria, if you like, especially in our gut, and that plays a very important role in our health. Then you've got cellular defenses, your macrophages and such that will attack foreign pathogens. Killer T cells, we'll talk a little about in a little bit. You also get some responses to infection. So we talk about acute phase response, and we'll go into that in a little bit more detail. And the inflammatory response. Now, what's important about, and specifically the inflammatory response, is the inflammatory response actually occurs not just in infectious processes. Pretty much any process in the body, there's an inflammatory component. And chronic inflammation has now been linked to a lot of disease processes, long-term disease processes. But it is complex, and once again, we'll touch on it, but we won't go into too much detail. Then you've got your acquired immunity. So as we know, there's certain stages in our life where we're at increased risk of infection. The first 3 months of life, we're relatively immunocompromised. We're very dependent on our mother for our immunity. And so, infants, neonates, sub 3 months are certainly at increased risk, but also at the other extreme of age, as we get older, our immune system is blunted, our innate responses are blunted, and so our risk of infection is, once again, starts to rise. Throughout life, our immune system can be affected by, our general health, comorbidities, as we talked about diabetes just before, but certainly medications that we take, people that are immunocompromised because of chemotherapy. So there's a lot of things that can really affect our immunity. But assuming that hasn't occurred, you generally get this acquired immunity from early on in life by exposure to certain virals, and you should be very familiar with this. We discussed COVID over the last few months, where the question of whether we will have this acquired immunity at the end of this COVID outbreak has been foremost on everyone's minds, and whether we should have this herd immunity. But it's an assumption that for every viral or every pathogen that you have this immunity that's going to last a lifetime after, and that's not the case if you do a bit more reading into infectious agents. Some, yes, absolutely, have a lifetime immunity to them, but others, they used to say that, for things like chickenpox, that if you had it as a child, you'd never have it again. And although, yes, your risks of having it later on in life are lower, it's still possible to get it. So you don't necessarily, for everyone, have the lifelong acquired immunity. But obviously acquired immunity can be gained through things like vaccinations. Now, I appreciate there's remains an unnecessary amount of controversy around this. There shouldn't be. Vaccinations have been researched more than I think any other medical intervention. But there's some cohorts of the population that are still very much against them, and that's an argument for another day. However, I think the evidence is certainly in. You just have to go to the third world and see where vaccinations aren't available. We've certainly come well ahead with our vaccination schedules as they are. All right, so now going back to acute phase response. So put simply, once again, this very complex process, but this is what happens in those, as you'd expect, acute phase post the introduction of this pathogen. And that's basically gearing up for the immune response. That's things like, vasodilating so that we can get the macrophages to the site. Blood vessels becoming more leaky, if you like, so that the macrophage can cross the vessel wall into the tissues and attack the infectious pathogen. But it's also the release of other proteins that are involved in the physiological response to attack within the body. And that involves complementary proteins, coagulation pathway, depending if it's a wound or not that requires it. And that also, those interleukins, for example, these interleukins here, tissue necrosis factors, alpha, all these things are involved in stimulating the brain. You get things like, from the prostaglandins anyway, development of fever that we're familiar with in infectious process. That's not to say that you always have a fever when you have an infection. Certainly we know that, once again, with extremes of age, you can often have what either be a cold sepsis, for example, where you're hypothermic, or no change in temperature, but certainly a presence of an infective agent. All right, so the complement system, I'm not by any means going to suggest that you need to remember that. So what I've done is linked you again to description of complement system. One of many. This is in the Encyclopedia Britannica. So it's a complex system of multiple proteins that act to eliminate infectious microorganisms. And we've talked about there's a bit of overlap with the roles of each of the systems. But basically what it's trying to achieve is the bursting of the foreign or infected cells, phagocytosis, i.e. the ingestion of it, and then inflammation of the surrounding tissue, which aids in the delivery of as I said, macrophages is one example, as well as the healing process thereafter. But by all means, do further reading into that, but it is quite a complex process, and I do not assume to know a huge amount about it. And certainly that doesn't affect the requirement for clinical practice. So what then happens is we talk about this immune response. I'll click on this and we'll bring this one up. So this is what I was talking about here. If you look at the screen where we've got this, the blood vessels becoming leaky, if you like, which is essentially, yes, fluid can shift across, but also these neutrophils and macrophages can move into the tissues and actually phagocytose or ingest whatever pathogens there. The macrophages will also release cytokines that are involved in obviously tissue repair. They release certain substances that, if required, will affect the coagulation cascade, which is obviously preventing further bleeding. But once again, in the Encyclopedia Britannica, it'll give you a description of the natural and acquired immunity and the process that is. And it talks a bit about immunization, the various vaccines, and it's an independent source. Have a bit of a read of how vaccinations are working. But essentially, very simply, what we see, if we're talking about a wound, is things like, and we tell everyone to assess it as heat, redness, swelling, tenderness, and pain. Now, there's a physiological process behind that whenever that occurs. So, as much as you can identify it, it's important that you think about what's going on. Why do you have heat? Why do you have redness? And that's all to do with the permeability of the vessel, the vasodilation. So, the heat is about, in fact, those vessels, the capillaries are vasodilating, you're getting much more blood flow there. And because of the metabolic process in the body, creates heat, and more blood flow equals more heat. So that's why you get that heat. That's why you get that redness. Swelling can be the fluid shift as well because of the leakiness within the vessels, and obviously then you get the leukocytes that move to the site of injury. And we know that some of the cytokines that are released can actually increase the neuron's pain response. So pain, you get this tendency, an increase in pain after the initial injury, and anyone that's had a wound will be quite familiar with that. Now, as we said, inflammation occurs in a lot of processes, and obviously not just in wound management. So what we've got here, and I'm not going to play it through, but is a video, and some of you would have seen these. Khan Academy does these, and several other resources that basically talks you through the inflammatory process. Once again, yep, absolutely, I know that there's so much more to read, but have a listen to that if you're a visual learner, and I'll give you an idea of that inflammatory process. All right, so back to our case study. So what have we learnt so far about what's going on? So we know this patient, he's a male, he's diabetic, so he's at an increased risk of sepsis. We know he's got a fever, so he's got an infectious process going on, or certainly an inflammatory process going on. So even before we've got to the patient, we know a little bit of what we should suspect. Now, at this point, I would hazard a guess, having done it myself, that many paramedics will be going, why is this patient calling? They've already waited 2 hours, why don't they just take them themselves up to hospital? What we've realized over a number of years is that it's our low acuity patients, or our patients that we leave pending. They're the ones that end up getting very sick and or dying, because our system is set up to, and not just ours but internationally, 000 or AMPDS systems are set up to identify the imminently dying patient. Now, this gentleman may not be imminently dying, but it doesn't mean he's not dying, so we often miss them. Anyway, so we get to this patient and he's assessed, and you find that he has the following virus. So he's confused, his rest rate's 30, so he's a bit tachypneic, he's certainly tachycardic. BP, maybe that's not bad. It could be quite healthy, 180, that's quite a healthy blood pressure. 120, obviously, everyone goes to as the ideal thing, but it probably is a bit low for a 56-year-old. So what does that little bit of information tell us? And this is where we get into the interesting stuff. So you would have heard of the term sepsis, and I imagine in kind with that you would have heard of this term over here called SIRS, which is Systemic Inflammatory Response Syndrome. Now, up until very recently, in the last couple of years, it was categorized as you had SIRS, then you had a source of infection, which might give you which then indicated sepsis, and then obviously you had septic shock at the most severe. Now, the thing with SIRS, and I've put the criteria for what indicated SIRS, body temperature greater than 38, less than 36, heart rate greater than 90, respirate greater than 20. Now, we certainly know that most clinicians don't actually count respirates correctly, which is a bit of a problem, but 20 is not that high. And when you look at the most common indicators of infection, a lot of people assume that's temperature, but it's actually tachypnea. So respirate's quite important. We should be counting that. But if you look at that criteria and you think, you could probably get someone on a hot day going for a run, and then I'm not including white blood cell count because obviously we wouldn't have that available to us in the pre-hospital setting, but they could go for a run and essentially easily go outside those parameters. And there's other conditions as well where, the criteria for SIRS is almost met without there ever being inflammation, let alone an infective process. So it's very much been taken out. I've just left it in here for a discussion point, but it's very much been taken out of the recent definitions of what sepsis is. And sepsis is a syndrome of physiological, pathological, and biochemical abnormalities that are induced by infection. We know it's a significant health concern, and certainly costs this is US numbers, but and this comes from, once again, I've provided a link to that Sepsis 3, which is the most recent international collaborative study into, I'll bring it up now, into sepsis. And we know it costs a lot. The incidence is increasing, probably due to reporting more than anything, but obviously that also cite aging population. But we do suspect that's obviously a greater recognition. That's plays a big part. What we do know now is, and this is the article up here, the third international consensus definitions of sepsis and septic shock. But what we do know is that the mortality for sepsis is about 10%. The mortality for then, if that progresses into septic shock, is approaching 40%. But even if you survive your sepsis, there's more and more research showing that there's significant psychological, cognitive disabilities after surviving sepsis. So it has profound effects both in the acute stages and certainly long-term for that patient. So how are we going to identify sepsis in the pre-hospital setting? Well, as we indicated with the SIRS criteria, that's not reliable enough. But what they've done, and I'll bring up once again the study on this link, what they've figured out is that in the ICU, they've got this thing called the SOFA score, which obviously, and this is a SOFA score, so it includes the Q-SOFA, and I'll talk about the Q-SOFA in a second, but the SOFA score includes things that we obviously are not going to be able to measure in the pre-hospital setting, things like mean arterial pressure, FiO2 ratios, platelet counts, serum creatinine, and so on. So what they developed was Q-SOFA. And the Q-SOFA, it's not about identifying sepsis as such, it's about identifying organ failure or the possibility of organ failure. And it's quite, all it requires is one that you suspect they've got an infection. And are they tachypneic? Do they have an altered mental status? And do they have a reduced blood pressure? Now, that gets brought into what is essentially a risk stratification tool. So rather than thinking a binary, do they have an infection, do they have sepsis, or don't they? It's about stratifying the risk. And the National Institute of Health and Care Excellence, if you have a look at their website, they don't obviously just look at sepsis. They look at a lot of different conditions and have some really useful guidelines. It is UK-based, but certainly still relevant to us. So when they talk about first deciding, could this be sepsis? So even before you decide it is, you just got to decide what are the chances it's sepsis. And it should be high on your mind as a potential cause. So rather than going and starting down the least risky condition that could be, start up high and think this could be sepsis. Look at the risk factors. We talked about gender, age, comorbidities, like in the case of our case study, a diabetic. Okay, so if they're neutropenic, for example, that's a significant risk factor. So they have recent chemotherapy. These are flags that should go, okay, well, this patient's actually, if it is infectious cause of their presentation, for example, the fever, then there is they've got certain risk profile. Now, if you decide it's not sepsis, that's fine, and carry on with your assessment. But if sepsis is suspected, then you've got to start looking at whether they've got high, moderate, or low risk criteria. Straight away, an alteration in the level of consciousness, behaviours, or mental status, that's a high risk criteria. It indicates end organ dysfunction, Then we look at respiratory rate. Now, our patient had a respiratory rate of 30, and you've got here 25 breaths per minute or more. So once again, he's in the high risk criteria. Heart rate 130. Our patient had a heart rate of 130. It's right on there. Now, it's got systolic blood pressure of 90 or less. Now, ours had 100, so he sits over here really. But does that make, just because that one number sits in there, that doesn't really make him moderate risk. He still sits in the high risk. There's other questions that we wouldn't routinely ask our patients, but we probably should. Or the family members, especially if they've got an indwelling catheter. Have they passed urine? What was the consistency? What was the sort of volume, roughly? Now, in the hospital setting, obviously, you might have a catheter and you can actually measure this. But just just a discussion with family could elicit some useful information. And then, how do they generally appear? So straight away, if we've got enough criteria, and our patients say he's in a high risk criteria, he needs emergency care, he needs it soon. And we'll talk a little bit about the time frames around treatment, because those are really important. But you can see, like, if we just thought, there's a possibility of sepsis, and go to the low risk criteria over here, normal behaviour, no high risk or moderate high risk criteria. So you really have to go. They basically have no other indication that this is sepsis. So they're almost certainly going to fall into the moderate to high risk, in the cohort of patients that we see. Okay, so you're a very conscientious paramedic. You've actually completed a much more thorough history and examination. And you've actually asked them about the medications. You paid attention, because a lot of paramedics and a lot of clinicians might ask about medications without really understanding what those medications are for or the side effects of them. And that can be really important. And you note that one he takes sort of triggers your eye. It's a methotrexate, and he tells you he uses that for his rheumatoid arthritis. That knows much about rheumatoid arthritis and inflammatory process. So it's easy for us to dismiss that. But as you can see, and I'm going to click on it now, I provided a link, just a little summary of its uses and some of its side effects. Now, I'm not going to give you the answer, but I'd suggest you read a little bit into methotrexate and then think about how that would impact on this patient's presentation. You've also done a very good and thorough medical assessment, because you identified that this patient was diabetic, and you know that diabetics are prone to ulcers. So you've actually looked on the bottom of his foot, and sure enough, there's an ulcer. What that tells us again is not just that there's an ulcer that probably needs treatment, but maybe that's the source of the infection that's causing him to be hypothermic and potentially quite unwell. So then it goes on to what we're going to do for treatment. Now, once again, there's so much to go into. So I've provided this link here to a video that talks about how antibiotics work. Now, it's only 7 minutes long. It's not a particularly long video. It is, I like to think, quite interesting. And it will give you an idea of available antibiotics and why they may or may not work on certain pathogens. I won't play that for now. Now, as I said earlier, obviously it's not just bacterial infections that cause sepsis. You can certainly get an inflammatory response and a septic presentation and or death in people with viruses. Now, that is less, well, depending on the virus, less common in your healthy young fit person. I'll show you some numbers in a little bit about the fit and healthy and how many still die from viruses like the common influenza. But this video here talks about antiviral drugs that are available for the flu, albeit they have some unpleasant side effects and aren't necessarily commonly used. It gives you an idea. It is a longer video. If you are only going to watch one video in this lecture, I encourage you to watch the one about the antibiotics. But certainly if you have the time, have a look at that as well. In terms of treatment from a paramedic point of view, once again, I provide a link to it. And this website is a really, really good resource. It gives you all the recommendations on treatment. So it links straight to the antibiotic section. But if you go up, you can sort it, see it gives you a lot of information. It's the NICE guidelines of the recognition, diagnosis, and early management. And it was updated back in 2017. It was the most recent update to guidelines, international guidelines anyway. And it provides links. But what's important is that they've researched this, and pre-alerting, just like we do for stroke, just like we do for STEMI, just like we do for trauma, that pre-alert lights up the system and gets investigation started earlier. So from the pre-hospital setting, the pre-alert is actually really important. But that requires that we identify these patients in the first place. And why that's important is that they recommend that the first antibiotics are given within 60 minutes. Now, they talk about in the NICE guidelines of arrival at an acute hospital, but some guidelines talk about 60 minutes from the first medical contact. So arguably, depending where you pick this patient up, there's not a lot of time between transport to then administer their antibiotics. Ideally, what they want to happen before they give any antibiotics, and it's not just giving a broad spectrum, this is giving the right antibiotic, is that they take blood cultures, because then they're able to then isolate what the organism is, so that if the initial antibiotics aren't working, they can attempt, depending on the pathogen that's involved. And that's why watching that video about antibiotics is important, to understand that some pathogens aren't going to respond to certain antibiotics. But they want those blood cultures because those take a number of days to grow before you can test and figure out which pathogen it is. But if you've already given the antibiotics, it can really make this quite challenging, and certainly the cultures may not be successful, and ongoing treatment may not be effective. However, and what we've seen, and I'll use QAS as an example, is that in the pre-hospital setting, and points where you may be greater than 60 minutes from a hospital that's able to give antibiotics, we're now cautiously discussing, because the only antibiotics that we carry is ceftriaxone, which is a broad spectrum antibiotic, but certainly not necessarily the one that you want for all pathogens. However, if you're far away from a hospital, because of the mortality risk of not getting those antibiotics in the first 60 minutes, there are some situations where if you made that phone call and said, this is what I've got, this is what I suspect, that we would give pre-hospital antibiotics in very, very, very specific situations. Now, other parts of the world, other agencies are looking at giving pre-hospital antibiotic for sepsis, but there are concerns over antimicrobial resistance, stewardship, etc. that do limit that for good reason. If we give this antibiotics to too many people that don't need the antibiotics, it's going to cause resistance. That's something to keep in mind, that probably evolve and change over your careers. Now, if you do find the patient does require fluids, then the recommendation in NICE is that 500 mils is less than 15 minutes. That'll probably be more in your shocked or approaching shocked patients. And what we know is that for basically after about an hour, only about a third of the volume of crystalloids that you administer was still in the intravascular space. The rest shifts out, and that's typical even in a non-septic patient. However, if you can imagine in someone who's got an inflammatory process where the vessels are more leaky, a lot more moves into the tissues. And we're really giving fluids to expand intravascular space, amongst other reasons. Also, if the patient does present hypoxic, we should target SATs of 94 to 98%. However you want to achieve that flow of oxygen if required. This is a critical illness, so that's why we still administer oxygen. Obviously, the exception would be those that potentially have a hypoxic drive, and there's controversies around that, I appreciate, but in which case you probably aim for a much lower SpO2 of 92%. As we did with our patient, we were very thorough, and we identified a potential source of infection, and that'll be done wherever there's a query of infection. There should be an investigation of where the source is. You won't always necessarily find the source, but certainly you should try to locate it. So, For any of you that aren't already aware, the Queensland Ambulance Service guidelines are freely available on the internet if you just search QAS CPGs, and they have one for a number of conditions. Now, obviously, I'm employed by QAS. However, I do reference them because they are a good resource. They are evidence-based. Not to say the other ambulance services don't have them. I know Victoria released one in the last sort of 6 months. That's also quite good. So make use of these. If they're freely available, absolutely refer to them. But they are not the source of truth, and certainly not something you'd reference in an assignment. They are purely guidelines to guide your decisions. So once again, they've looked at, you'll find that the high risk and moderate risk criteria will be very similar between this and the NICE criteria we showed before. They give us a definition that fits quite well within what we've already discussed. And then they talk about some risk assessment in terms of red flags. And red flags are something that appears in our guidelines quite frequently, and they are important because, and I'll touch on a little bit about bias towards the end of this lecture, but certain things that we need to think about, and we typically, it's like this one, representation to a healthcare professional within 48 hours. Now, we often see it where we get these patients who have got some infectious process, seen their GP, GP's put them on antibiotics, and 24 hours later they call the ambulance because they still feel pretty ordinary. And traditionally what's happened is we've gone, well, you haven't given a chance to work, you need to give it 3 days. But what they've looked at is patients that have deteriorated, and what they found is that there's this independent risk where, if they are, say, representing within 48 hours, that in itself is a risk factor, because they are in themselves are identifying, and maybe not every single patient, but certainly a large number are identifying that they're not doing okay, that they are sicker, and that's something we need to take, give a lot of attention to. Certainly, if another healthcare professional or parent, if it's a child or family member, has concern, we should be professional enough to go, don't dismiss that concern, because all that's going to happen is if they're right, you've got an egg on your face, not to mention a lawsuit. But just take it into account. Talk through the problem with them. Yes, there are people that overreact, that maybe are a little bit more cautious. But as a professional, it's our job to decide that minority, which are very, very few, and the ones that have genuine concern. And anyone that's had a child or a sick family member that hasn't been listened to by their doctor, their nurse, their paramedic, or who they've been treated for, it's incredibly frustrating. And they don't necessarily stand up for themselves. Some will, but others won't. And you don't want to be that clinician that didn't listen to the family member and now their loved one is either very sick or dead. We talked about these extremes of age, recent trauma or surgery, any invasive procedure, and if they present with infection, that the source of infection may well be that where that procedure was performed, and that won't necessarily respond to just antibiotics. Indwelling medical device, IDCs and such, immunocompromised, neutropenic, asplenia. So that's your patients, and we see it in bike rides, for example, who their abdomen hits their handlebars, and they end up losing their spleen. Now, you can live without your spleen. The problem is you're dependent on antibiotics for the rest of your life because your immune system's affected. So there's a bit of information there. In kids, asking whether they're immunized, it's not to trigger then an argument with the patient over the pros and cons of immunization. We just know that if you are unimmunized, you're at risk of pathogens that the people that are immunized aren't at risk to. So it's important. Aboriginal and Torres Strait Islanders, they are overrepresented in the statistics for sepsis. So they are a risk group. Vital sign criteria, depending on age, is important. And certainly trying to memorize that would be hard, so just having a general understanding. And then in terms of flow, so, the one QAS guidelines anyway that we've put up there is evidence of meningococcal septicemia. Now, this is incredibly rare. I think in a number of years I've been in this, maybe been 2 or 3 administrations of ceftriaxone for suspected meningococcal septicemia statewide. However, it's a scary disease. It is rapid, and it does affect the young and healthy. So it sits up quite high there, and I'm not going to get into that specifically at this point. Then it's about assessing your patient's risk of having sepsis. It's not saying, yep, they definitely do have it, or yep, they definitely don't. It's going, how likely do they have it, and how sick are they? So really, there's no risk. There's low risk, moderate risk, and high risk, and that's going to guide what you consider. Now we talk about adrenaline down here. Now that's not something that you're going to give intramuscularly. Adrenaline is something that you give after you've given quite a large amount of fluid, if you need to basically clamp down the vessels, get the alpha effects to maintain end organ perfusion. So that's not something that's very rarely going to be required, thankfully, and certainly not something you're going to do just by giving 300 mics of adrenaline intramuscularly. All right, so back to our case study. When we decide on our treatment plan, and I've touched on it about, where your location is, are you going to get to that antibiotic within 60 minutes if you think they're at a high risk? Are they just moderate risk? Are they low risk? Is this a patient you want to leave behind? Certainly in our case study, if any one of you is suggesting this is a patient you want to leave behind, you've completely missed the mark. But you will get patients, and I'll talk about bias in just a second. It's important that we locate that source of infection, and then we initiate treatment. Now, this is not definitive care. Not every patient is going to require lots of fluid. A lot of your potentially septic patients probably won't get any intervention from you. And talking about interventions, be careful with just cannulating people for the sake of it. That in itself introduces a source of infection. So we've certainly moved away from that in recent years. So if your patient were shocked, we know that their mortality is increased. We know that, yep, we can give them fluids, but fluids is not going to change a huge amount for this patient. What they need is an antibiotics. They need them early. They need an identification of the factor, the reason or the location of their infection, and they need that treatment early. So I kept touching on this. Most of our patients won't necessarily be this obvious. We get a lot of patients with fever, and I would argue anecdotally that 1 to 2 every couple of years, young, healthy, no comorbidities, in their 30s, people die from the flu. And yet we routinely get very frustrated for the 30-year-old man that calls us. And we joke about man flu and the rest of it. But these people, yes, fewer than, in the 80, 90-year-old age group, die from influenza. But they do die, so you don't want to dismiss that. So what I encourage you as a clinician, it doesn't matter what job you're going to, just ask yourself, when you're about to leave that patient, what can't I afford to miss? And am I sure it's not there? If you've got a patient with a fever, and yes, 90% or more of your patients probably will be fine with their fever, but what can't you afford to miss? And even in my practice in all the years I've done this, I still, if I cannot give a categorical answer to my patients, all I can say is, I haven't found anything, however, there's still a possibility of X, Y, and Z. It's not putting it back on them to make a decision. I need to give them all the information that I have, and then they make the decision. Don't be swayed by the dispatching. Like dispatch code 2B, we now know that our 2Bs and 2Cs are the ones that we don't get to soon enough, and they're the ones that get sick and die. Don't be swayed necessarily by a doctor saying it's minor. Make your own decision. Do your own assessment. But by the same token, if the doctor's concerned or another health professional or nurse is concerned, just at the end of it go, I gather that you're quite concerned. Can you explain to me what is concerning about this presentation? And let them tell you and listen to them. Never dismiss a headache for multiple reasons. Most are benign, but you don't want to miss the one that isn't. So when you find that you're saying, then these are commonly spoken by paramedics, when you find you're saying these things, just think twice and think, what can't I afford to miss? And then if at the end of that you still think that this is a patient that you can discharge and leave at home, then that's up to you. But have a think of this. So this is the death rate of influenza in 2017 across different age groups. And there were 21 deaths for people sub 44 years, or sub 45 years, I should say. 21 people. Now, that's not very many, but do you want to be the paramedic that left that patient behind because you think it was just influenza? And there's no magic diagnostic criteria that will diagnose the 44-year-old who's going to die of influenza and the one that isn't. That you just have to risk stratify them. And if after all that, they still have that immune response that results in them being that one that does die, but you've left them behind, as long as you've done a thorough assessment and no one could have picked it, then you will be investigated, but hopefully be found to have done the right thing. Now, obviously, as we get older, that risk of death from influenza does increase. So it's not a benign illness. Yes, in terms of per 100,000 of population, it's quite low, and there's other things that kill more people, but it's by no means a benign disorder. Anyone that's had influenza and can recall it, it's still not a very pleasant disease to go through. So if you want a bit more on sepsis, these are quite old graphs. I couldn't find anything up to date in Australia, but what's important is that, you know, we do see hospitalizations in the younger patients. We do see mortality in the younger patients, even down to, you know, obviously the very young. We do see it, especially if they have comorbidities. But overall, you know, we're still seeing, you know, anywhere from lowest 10% up to 40%. So still quite high. And once again, if you click on the link, you'll get a bit more information on sepsis to have a look at. And this is the Sepsis Alliance. So they're a really good resource. Everything from explaining what sepsis is, education. You can go and there's some webinar series if you want to learn a bit more about sepsis. Get involved. Obviously, research in your later career might be something you get into. Lots of information guides. Obviously, coronavirus features quite highly. So there's a lot of information there that you can now access. What I'd encourage you to do is continue on with your reading, ask questions. You will revisit the concept of sepsis, infection, and so on throughout several of your subjects in the next couple of years. And if you do have any questions, feel free to either email. I will no longer be at QUT by the time you view this lecture, but I should still be associated with it too. I'm more than happy to have questions emailed through to me. My details will be on the Blackboard site, or obviously Shonel will be leading the unit, and she'll be able to answer your questions. I hope this was a useful lecture, and I hope to speak with many of you next semester.